We know how to fight the epidemic, but patients in the South still aren't getting the treatment they need. Houston, in his State of the Union address, President Trump surprised Congress by asking for a commitment to eliminate the HIV epidemic in the United States within 10 years. I'm a physician who specializes in HIV and AIDS prevention in a city with one of the highest infection rates in the country, so that's music to my ears. But the president needs to know that we're going to fail if we don't start working much harder. After nearly 40 years, we finally have the biomedical tools and the public health strategies to end the HIV epidemic in America. The winning strategy goes like this: increase the number of people who get tested for HIV, and start those who test positive on antiretroviral therapy as soon as possible, which helps prevent transmission of the virus. Those who test negative but are vulnerable to infection because of sexual activity should take pre-exposure prophylaxis, or PrEP, the daily drug regimen that reduces the risk of getting HIV. The tragedy is that those tools are sitting on the shelf in many parts of the country, especially the South, where HIV rates are still rising among some groups and where AIDS disproportionately afflicts African Americans. Just this week, the Centers for Disease Control and Prevention reported that the progress in HIV prevention has stalled. Big cities on both coasts, where AIDS was concentrated when it was officially recognized as a health condition in the early 1980s, have deftly managed the disease. San Francisco was once ground zero, yet in 2017 new HIV diagnoses there fell to 221, a record low. The city's Department of Public Health credits PrEP and a Rapid Start program that gets those who test positive for HIV into care within 5 days. Other urban areas have made similar strides. In New York City, new HIV infections dropped 26% from 2012 to 2016. In the city's clinics, people are offered treatment as soon as the virus is diagnosed. Demeter Daskalakis, the Deputy Health Commissioner for Disease Control, said this program is working with staggering success. The HIV epicenter in the United States has instead shifted to the South, which now accounts for more than half of new infections and nearly half of deaths directly related to HIV. 8 of the 10 states and all of the 10 metropolitan areas with the highest rates of new HIV diagnoses are in the South. The region had 20,000 new cases in 2017, compared with 6,000 cases in the Northeast. Even after learning they have the disease, Southerners face serious hurdles to getting care. A lack of public transportation, in both big cities and rural areas, makes going to the doctor more difficult. The cost of medications can be prohibitive, especially in a state like Texas, which has the highest uninsured rate in the nation. Not enough HIV-positive patients are beginning treatment within a month of diagnosis, even though research shows that doing so improves health and reduces the risk of transmission. Far too few people who could benefit are taking PrEP. And of course, there is lingering stigma that keeps people who need help on the margins. Over the past few years, there has also been a demographic shift. African Americans now represent 44% of all people infected with HIV, nearly 4 times their proportion of the population. Hispanics, 18% of the population, account for 26% of infections. Houston's population is 44% Hispanic and 23% Black, and HIV rates among young people of color here are rising. HIV rates among Black women are 17% higher than among white women. We are making slow, steady progress. The joint United Nations program on HIV/AIDS last year honored the Ponce de Leon Center in Atlanta, which serves more than 6,000 people a year, most of them living in poverty and uninsured or underinsured. The center provides not only HIV diagnosis and treatment but also financial counseling and nutrition. And nationwide, while we don't yet have a cure, the medical breakthroughs around HIV are impressive. Thousands of Americans are living happy, successful, long lives with the infection. But this makes some of the cases I see all the more distressing. I had a patient who died last year of an AIDS-related cancer at age 31. Another woman, who has been infected with HIV for 15 years, is 41 years old and unable to get out of bed. Little can be done for these women, the infection having been diagnosed late in their illness. So, yes, we can meet the president's goal of ending AIDS in a decade, but only if we race to get our new tools more efficiently and equitably to those who need them. Charlene Flash is an infectious disease doctor and associate chief medical officer at Legacy Community Health, and a clinical assistant professor at Baylor College of Medicine.